Okay. Good afternoon, everybody. Thank you all for joining us today. Welcome to this month's event for the Initiative on Health and Homelessness at the Harvard T.H. Chan School of Public Health's Research and Seminar Series. We are so excited to welcome Ben Bradley from Community Solutions to present his team's work at the intersection of public health and homelessness. Before we begin, I just want to let everyone know that this seminar welcomes participation. So at some points during the talk, Ben is going to pause and pose some questions to the audience. So we're hoping we get some good engagement from you all. So keep your listening ears open. All right, so Ben is a systems improvement advisor on the catalytic projects team within Built for Zero at Community Solutions. Prior to joining Community Solutions, Ben worked in a variety of roles in the nonprofit sector, championing causes such as public health, contraceptive access, data collection in remote settings, national service, homeless service, workforce development, and food insecurity. So we're so excited to welcome Ben. And I do want to make a quick note. If you have questions throughout the presentation, please put them in the chat. And then at the end of the presentation, we're going to open it up for audience questions. So at that point, you can either put your questions in the chat or use the raised hand function, and we'll call on you to unmute yourselves and ask your question. So with that, I'm going to turn it over to Ben. Welcome, Ben.
Thank you. I'll do a quick audio check. If you're on video, give me a thumbs up if you can hear me all right. Great. That's a lot of thumbs. I like it. Thank you all so much for having me and for that lovely introduction, Emily. My hope today is to lead you through an engaging, interactive session that informs you on our budding public health work here at Community Solutions. With that in mind, I want to first start by providing a little bit of background on Community Solutions and our initiative called Built for Zero. One second, having slide trouble. All right. So here at Community Solutions, we are working for a lasting end to homelessness that leaves no one behind. Our team envisions a more equitable society where homelessness is never inevitable, inescapable, or a way of life. And to illustrate how we came to these beliefs, I first want to quickly lay out the history of our organization. Our story really begins with building affordable housing. Our president, Roseanne Haggerty, founded an organization that created nearly 3,000 permanent supportive units. And while that ended homelessness for residents in our building, we could not ignore that homelessness in the city continued to rise. From there, we shifted our attention to understand how we as an organization could help communities strengthen their systems to more quickly connect their neighbors with housing. We launched a campaign, and by its end, the 186 participating communities had exceeded our goal, housing 105,000 of our neighbors. Despite this important achievement, we saw that none of these communities had ended homelessness for a certain population. And this led us to create an intervention called Built for Zero. So Built for Zero came after the 100,000 homes campaign that I mentioned. And in that, we really realized that we were asking the wrong question. If our aim was to end homelessness, we needed to not count up to housing placements, but understand what it would take to help communities drive homelessness down to zero. And the evolution of our work really led Community Solutions to understand that ending homelessness requires more than an adequate supply of affordable housing and support services, and more than just speeding up the process of connecting those experiencing homelessness to homes. It also required a new way of thinking and working built upon a community-wide commitment to bringing every person home. This required a rational housing system that provides accountability for measurable results and a coordinated group of leaders with the flexible problem-solving skills common to all great social change efforts. And today, as it stands, Built for Zero, we have 105 communities, referring to continuums of care that usually cover city or county regions, participating in Built for Zero as a whole. About a quarter of our country's COCs are represented in Built for Zero, and collectively they're proving homelessness is solvable. 14 of those communities have achieved functional zero, a standard where homelessness is measurably rare and brief when it does occur. Although our work at Built for Zero is robust, our team is divided into focused portfolios that allow us to really drive change through a myriad of different solutions, coaching, and strategies. Of those portfolios, I'm a member of one called Upstream Strategies. So Upstream Strategies, we really try to embody our name and move upstream wherever possible. We're also challenging ourselves to think of how we can prevent problems instead of just reacting to them. And as we think through these problems, we look for catalysts that will be transformational in this work. And if there's a strong base of research, awesome, we're gonna build on it. If there's not a strong foundation of research, we wanna be the ones that dip our toes in the water and learn about that work to see if we can build that evidence base to drive change throughout the entire world. Further, we ask the question, what systems influence and interact with the homeless response system? How do they impact one another? And once we have tests with results and evidence-based, our goal is to really scale and replicate that model or toolkit wherever possible, whether that's within our Built for Zero communities or through white papers, research, and open source tools. Among other projects in our portfolio, I want to call out a few that just may be of interest to folks on the call here. We have a healthcare pilot that involves 5 communities and their local COC leaders and healthcare system leads working together on solutions to complex issues like discharge planning, complex care, and all sorts of other issues that come along with the healthcare system. We also have a team working with 6 communities to understand and map the systems that flow into homelessness, particularly to understand how to best stabilize the local housing systems in those communities. We also have a group leading efforts to create a sustainable, scalable model for communities to routinely and meaningfully engage people with lived experience of homelessness in their communities in making decisions, policies, and more. And here on the bottom right, you'll see our public health intervention, which is the newest addition to our project portfolio, and it's also the one that I'm going to be diving into today. So I'm going to throw out an assumption here that all of you have heard different headlines over the last few years about how there is a health crisis that involves housing, all these different things in different cities. It goes from things like mental health to a public health emergency, and all the different ways that it could be approached. There's also some really great research and articles that have come out in recent years about how these two sectors intersect, but there's not always a strong evidence base or toolkit that really could be applied to a community level. And so with that in mind, I'm going to stop here for the first time and throw the question to you guys. So we at Built for Zero challenged ourselves to ask the question, how do we see the relationship between public health and homelessness? We asked a lot of folks about this, but I want to first, before I tell you what they said, I want to hear what you guys say. So if I could have 1 or 2 volunteers that be willing to kind of come off mute and just jump in what they think, that'd be awesome.
Any volunteers?
Glad to say a quick word here. I see the relationship as one that's bi-directional and complex. And if your health is compromised, it compromises your ability to retain housing in our current system. And if your housing is compromised, it compromises your ability to maintain good health. And for that reason, they can't be separated from one another.
It's awesome. Thanks, Brett. Anybody else? Any thoughts?
I know that it seems like, oh, go for it.
Sorry, Kirk. I just wanted to add in as well. I see the relationship also from like a multi-sectoral, like multidisciplinary perspective. Homelessness requires so much involvement from government and healthcare professionals and policymakers and just the whole spectrum, and of course unhoused individuals themselves. So I think there's a lot of interdisciplinarity that you can see in the relationship between them.
I love that. Thanks, Audrey. Kirk, anything you want to add there?
Hey, maybe naively, I just sort of assume that the public health department in any town has somebody working on it. It just seems like it's got to be part of somebody's job somewhere, right? Every town is experiencing it, so should be baked in. Yeah.
Well, I think that's a perfect segue. So what we did was we posed this question to our communities. And we decided it would really be important to learn from them. We have these 105 members. We would love to learn about what's happening in these different communities. And one of the first questions we really asked ourselves is, before we distributed the survey to them, is we really wanted to dig into some key data that was already out there. This map that may look a little funky on the screen here is actually a combination of a data set from the National Association of City and County Health Officials that geographically outlines local health departments. And embedded within that is the same geographic map of our 105 member COCs. And in our early research in this space, we really kept hearing this refrain from folks that health departments vary so widely in scope, structure, and geography across the country. So we really wanted to look at to see how often do COCs and local health departments align geographically, and therefore, how often do their focal subpopulations also overlap? In the screenshot you'll see here, areas identified in red are one-to-one alignment, meaning that there's one local health department in the same geographic area as the COC. Blue represents areas where there are two health departments within one COC, and then gray is when there are more than two health departments within one COC. This is really important when we think about things like if there's an encampment that folks want to respond to from the homeless response system, they really need to know what health department could help support that work, how they could reach out to that, who to contact in that way. Also, in areas where there are multiple health departments, they might have competing programming priorities, and they all might apply to the focal population slightly differently. And so we then distributed a survey. So we sent out a survey and we had over 50 of our COC leaders respond to us. And so again, this is coming from the homeless response side. And we asked them questions specifically about their engagement with their local health department or public health authority. And here you'll see that it was clear that COVID-19 really drove collaboration between these two systems. Only a small majority, roughly 8%, saw less than 3 response activities during the pandemic. And as you see the response activities on here, I think they're things that we would assume were happening kind of across the board. But knowing that COVID really built some of these partnerships, we wanted to know, were there plans to sustain them in the future? And one of the questions we posed was, what is your relationship with your local health department? And we learned that 87% of COC respondents felt they had a strong or at least some relationship with their local health department. And although that was reassuring in certain ways, we really wanted to dig in a little further to see what that looks like in practice. So here you'll see a couple of example support services listed here on the side: shelters, encampments, during support in time, the point in time count, mental health counseling, and Medicaid. So of those issue areas, how many of them were the homeless response system collaborating with their local health department? And you'll see that on the bottom here, 11 communities said that there were no support services of those listed. And this was an interesting data point for us because it could be that the services provided locally just might differ from the examples that we provided, or there might be a true divide between the local health department and the COC. And then conversely, we are really excited to see that we had some communities where we had really strong partnerships in place. And that seemed like a really good opportunity to start digging in and do a little bit of peer learning. And so from there, we just went deeper. Common theme here. And we really wanted to start with communities where there were strong, robust, ongoing partnerships between local health departments and COCs. Like I mentioned before, scalable, replicable models is what we're all about. So how can we learn, package that, and share it out into the space, knowing that health departments vary so widely? Although we have many more than what I'm about to call out here, I've chosen a few of these really exciting bright spots, as we call them, that I just want to highlight here. And we do have plans to do more of this, and I can share more in detail, but just wanted to give you kind of a tease here. So first up, we have Hartford, Connecticut. Put simply, the local health department and COC formed a partnership during the pandemic to provide testing, vaccination, isolation spaces, and more for the local homeless population. On the heels of that partnership, both organizations flagged that an ongoing challenge was a lack of coordination in responding to encampments in their community. Together, these teams created a smart sheet protocol that automatically triggered a cross-sector response to any encampment challenge that needed a solution. Now, in the present model, when an outreach team is sent to an encampment to address an issue, they can request local social workers, nurses, even epidemiologists to accompany the team as they reach out. the second example is Fairfax, Virginia, where the local health department provides nurse practitioners to serve as care coordinators within shelters. And these providers not only provide direct care, but also help identify proper provider referrals and actively connect individuals with the care best suited for their needs. We heard from the local team that by having these providers co-located within the shelters, it really helped eliminate barriers to access like transportation and travel, and instead made it convenient as possible to provide equitable access for all. And the last one to call out here is San Diego, California. Now, San Diego is a really exciting place because of their cross-sector partnerships in many other ways. They also have a really dynamic community health exchange where patient-level data is shared across providers to unify the local health system. But the key example I wanted to throw out here today is actually the city's response to homelessness, which is that San Diego, as a city, has declared homelessness as a public health crisis. Now, I'm sure many of you here know what happens when a community or the federal government declares something a public health emergency. We recently learned about how the COVID-19 pandemic public health emergency for the country is winding down. So it's different here, where San Diego is hoping that this declaration will unite their local service providers, healthcare systems, DOC, police force, and more to work together to solve housing and homelessness problems in their community. It's really early. It's September 22 where this happened, and we will really be excited to see how the action follows the intent here. And I think that's the key kind of measurable here, but there's a way where you can bring people together and really drive that. And so I'm going to go back to you all here. And I'm going to say, you are the mayor of a city. Congrats. You just got elected. You have unlimited data sets. You can look at any data, any kind of indicators that you want. What would you look at to understand whether you feel that homelessness would be a public health crisis in your community?
I think I'll probably start with like health outcomes. So for instance, if there's a way we can look at like mortality rates and maybe causes of death among the community, I think that's a really stark way to raise awareness of the issue from a very like grand standpoint.
That's great. Thank you.
Deb said also the number of people living unsheltered and shelter utilization. And Diana said number of hospitalizations of people experiencing homelessness, deaths, referrals to services. Alexandra said political/public outrage. And Ryan said mortality rates in homelessness versus housed, disease burden, linkage to HIV, Hep C rates.
These are all awesome. They're great. Bob, did you want to add something?
I was just going to make it simple and say if there's more than 2 people homeless and they're having health problems, let's do something to help them. And if it's declaring a public health crisis, then let's do it.
Thanks,
Yeah.
Bob.
So a lot of people nodding to that. That's you got an easy crowd to win over here. Well, thank you all for those points. I'm going to keep jumping in. We have one more section here, and then I really just want to open it up to talk through this work with all of you. So as I said, we learned so much from talking to our communities, and it really excited us for what possibilities lie ahead. As one interviewee really highlighted for us, the key learning was to build a common ground in terms of population and priorities. And these systems clearly need a shared vocabulary for them to effectively work together. And that was one of the first trends that we really pulled out of these conversations. Is a lack of consensus around the definition of what falls under the umbrella of public health or a local health department. And in general, what we heard kind of across the board was that many local health departments did not feel that homelessness fell under the scope of their responsibilities. And I think it's a really exciting thing to unpack, because that would help us dive into a little bit more buy-in, ownership, things like that. The second point here that we really heard a lot was about data. So we heard time and time again just about how important it is to have data, whether it's shared once or on a recurring basis. And there was really no stronger way to identify, measure, and monitor these problems at hand. But both systems also have complex cumbersome technology barriers to overcome. And so we have to look at the examples where it's been done before and figure out, is that a once in a million shot, or is that something that we can learn from and package and replicate in other ways? And then lastly, really beyond just public health, we heard a call to loop in the local health systems. Health is health, right? A common term sprinkled across all of our conversations and research is health equity. And we really felt that encapsulated a lot of the work that we're doing. And we really wanted to actively consider how this work that we're doing in our public health project is very complementary to the healthcare pilot that I mentioned earlier. How can we share learnings across that space, and what do they have in common? Okay, so what's next? We just talked about some really exciting research, some things that we've dug into. All that's great, but what matters is what we do with that information and how we drive that work into our communities. And that really involves something we call a theory of change. So in developing this, we met with over 30 experts that ranged in scope from former leaders of state and national health organizations to homeless response leaders to individuals that were providing direct care for individuals on the street. And we really felt that we needed to inform our work with a theory of how we think change will come about. And at Community Solutions, we really lean on the Institute for Healthcare Improvements model for thinking about systems change. And that's where this theory of change comes in. And so there are 5 key drivers that are on the screen here. I'm going to pause for 30 seconds and let you all read them, and then I will kind of talk through them. Okay. If you didn't get through it, I promise there will be time. So first off, I want to start with the light blue here. We heard a strong urge to encourage local health departments to consider establishing programming and policies specifically for the local subpopulation of individuals experiencing homelessness or at risk of homelessness. Although there's good reason why programming is currently disease-centric, there may be needs and customizations that would be best suit the needs of the local homeless population. And this requires some collaboration with the local COC. And further, this allows improved access to shared funding streams across both the homeless response system and the local health department. And that was so important that we even broke it into its own, which is here in orange, which is strategic funding. So funding and grants will drive this work. And there's been a clear shift in kind of the national organizations and foundations to work towards equitable health solutions for all. There's exciting examples of braided funding between these sectors, and there's a lot of opportunities for these two sectors to combine and work together on projects. It's all about communication and collaboration, which is in the middle here in maroon. So collaboration is so important. That's why it's really represented in the middle of this diagram. And we heard over and over that the role of public health is as a convener, and that is one of their superpowers. And there's such a great benefit that comes from that perceived neutrality of a local health department, as well as its connection within the government. So they have the dialogue and the space and the voice that the local COC may not already have. They're able to build bridges and spaces where the COC does not have time or relationships to really start out. And this really helps them advocate for policies and programs of need. And we think that's super important as we move forward in this space, but we also know that we'll be limited by what data we have. So that brings us down to the bottom left. I don't know if that's teal, but we'll call it teal for now. So because of the lack of coordination between local health departments and COCs, there's little data shared right now between the two that helps understand the need and the scope of the problem locally. For example, we talked earlier about mortality information, right? So there's limited programming that works to highlight the mortality of homeless individuals outside of select cities around the country. Medical examiners and coroners have limited knowledge and evidence to identify a deceased individual as homeless or experiencing homelessness, unless it's where they were found. Thus, there's no quality data from those avenues that allows us to inform policy at large. There are researchers working on it. There are a lot of people thinking about this challenge, but it's one of those areas where we really need to be able to connect different systems to understand shared definitions, to improve the quality of our data, to drive policy. And the last bit I want to mention here is the Medicaid and Medicare in green here. So depending on what research you're looking at, between 50 and 70% of individuals experiencing homelessness are either uninsured or enrolled in Medicaid or Medicare. There exist waivers, including really exciting proposals in states like Washington and Arizona, where housing support is approved by Medicaid, but the waivers are commonly misunderstood by our COC leaders. And it also is found that it's not something, a process that they fully understand enough to then digest and share out with their individuals that they serve, the clients. But by connecting state CMS offices with local initiatives and leaders, there remains a lot of promise for a better tomorrow where these systems are actually complementary. So I just threw a lot at you, a lot of text, a lot of talking, colors even. What's your first impression?
So Ben, this is Howard Coe. Let me start. And my team and I have had the pleasure of interacting with you and Andy and of course Roseanne for a long time now. So we really appreciate you presenting at this seminar. And first of all, thank you for calling public health a superpower. No one ever called us that. So it's nice to know. And yeah, we are proud that we are so broad and interdisciplinary. And so with collaboration with you and other wonderful colleagues, you know, we can make this core to public health and not something that just falls through the cracks time and again. I was really interested in seeing your response survey data, and you noted, Ben, but I will reemphasize that I think the homeless providers have done a phenomenal job through COVID caring for people experiencing homelessness. It may be clinical care at its very best. So maybe my other colleagues who are on the streets can respond to that. I'm wondering if you repeated that survey over time, if you still see that level of response in some communities. The data stuff you have brought up very well is very, very tough stuff. Thank you for reminding us that we don't even have good mortality data. I mean, we have a little bit in spots here and there. One of our student researchers did comb the literature looking for that and didn't find a whole lot. And then I think the link to Medicaid and Medicare is a really very important point, and also connecting with healthcare systems. Our Boston Healthcare for the Homeless program, Dr. O'Connell and Julie Bogdansky, I think have unique ties with academic medical centers, BU and Harvard, which really makes a big difference, I think. So just tying it all together and bringing it closer together with the continuum of care efforts that you mentioned, I think is really key. So we have been honored to be part of this and honored to contribute to your working through of change. So thank you.
Well, thank you right back. Yeah, I want to lift up Boston as an incredible example of having some of the strongest mortality studies out there, as well as one of the strongest healthcare for the homeless programs out there. I think when we are thinking about this work and scoping and scaling in this space, it's looking at pioneers like that we can learn from. So yeah, I want to keep this open here. Anyone else, any strong first impressions or things that you thought?
Ben, I'm just thinking that it sounds like, you know, collaboration between groups and on the services they're providing, or, you know, taking care of the client, or collaborating on bringing funding sources together. All of that seems like, you know, sort of like simple on the face value, but that's a lot of work. Collaboration is hard, and that takes a lot of time and energy. How are successful systems or cities managing that in addition to their regular workload and the regular capacity challenges that they've got? It takes, you know, sort of like a special extra effort to do any of this stuff when some of the systems are so overloaded.
Yeah, we heard that both systems, you know, capacity is one of the biggest challenges here. As we think through trying to work with communities in this space, I think the biggest question is, how do we bring this work to them in a way that is really efficient with the time that they're willing to put in? And whether that's grant funding, whether that is bringing in project managers or what have you. And I think, like you said, there's a lot of really exciting things here. And it probably is that we need to start small and be able to establish some relationships first, and then be able to kind of snowball that into much bigger change around the community. But open to anyone else's ideas if they figure that part out too.
Hey, Ben, this is Jim O'Connell. Nice to see you, by the way, and thank you for, as always, a spectacular putting together of a very complicated problem. One just thought question I have, which is something we've been struggling with a little bit, is that the problem with homelessness is usually that it involves so many sectors that to narrow it down to one sector or ask that one sector to address it, which, arguably it might say here, public health, sort of lets everybody else off the hook or something. And so when you mentioned that the superpowers, Howard underscored, of public health is to convene, I think sometimes we feel like this is not a health problem. It's not a public health problem. It's not just a housing problem. It's a business problem. It's an education problem. So how do you convene, or how do you use the tools you guys are going to have now, which is really, a pulpit that is to die for, to sort of get those sectors together, not just say, I don't know what's happened in San Diego. So the data today that their numbers have gone way up, but how do you make it so the city doesn't say, oh, that's a public health problem?
Tremendous question. I'll give my thoughts on it, but I welcome this to the group. I think there's a lot of smart folks here that might have a better answer. I think in our research and when talking to different folks here, the biggest thing that came to me was that there's a lot of shared goals between these different sectors, just phrased slightly differently. A lot of public health, they talk about population health, health equity comes up a lot. I think there's a real possibility where mapping out some of their priorities and goals within a given year or 5-year plan would help see how some of these areas are either competing or complementary to one another. I don't know if it solves the burden of responsibility that falls on public health there. But I do think that the interdisciplinary nature of experts in the public health space are able to kind of see across that in a lot of exciting ways. And it's one of those things that we within Community Solutions are thinking about, is why we're kind of approaching these things kind of sector and system by system. And our hope is that, a few years down the road, we have a clear system map of how these systems interact with one another and be able to really combine learnings across. But anyone else, any thoughts on that? Or Dr. O'Connell, anything you want to throw back?
No, I think that's fabulous. That was a great answer. I appreciate it.
Hi, this is Claudia, also with Healthcare for the Homeless. Hi, Jim. I guess one thing I've been thinking a lot about is like international homelessness and displacement generally outside of the US. What does that look like? I went to this talk a few years ago in DC at Brookings about internally displaced people, and they're just like these kind of big intractable seeming problems, but as far as like systems change goes, I'm appreciating hearing what your approach is, because it takes all of these sectors working together. Also just like knowing people. I have a friend who's a city planner in San Francisco, and thinking, they're coming up with their 30-year plan for a lot of different environmental needs within the city. So like forming those collaborations, forming those partnerships, and being able to have like a cross-disciplinary ear, for lack of a better word, I think is also really helpful, because there's so many different priorities the city has. But I think one thing is with housing is that, and shelter really, is that everybody needs it. And I've had some small successes, even just like convincing my friends and neighbors to vote for politicians who care about policy issues, because it's like, if you don't have affordable housing that's middle income housing, then how, helping people to see how these issues are tied together, I think also helps in a broader community sense. People care about and put in place leaders who are going to have an impact. Sorry, my thoughts were all over the place, but I think that's important too.
Oh, I completely agree. I think that's a great answer, and thanks for adding all that. I think kind of like has been said, how big can we make this table? And I think the question is, can we start with small conversations that are intimate, close, about folks that have stories to tell and priorities to focus on, and then find ways to really get that into the hands of policymakers and the power of the local folks that are going to vote for these individuals that see the problems every day. So I have a lot of hope. And I think that's the other thing that's not on this theory of change, is a lot of hope for where we could go with this work. I want to go ahead.
Oh, no. I just wanted to ask a question while we're on this topic of bringing sectors together. There's a question from Alexandra in the chat directed at Dr. Coe and Dr. O'Connell. Do you think anchor institutions could play a role in bringing these sectors together? If you're up for it. Oh, Dr. Coe, you're on mute.
Thanks, Emily. So I'll take a first crack at that, and I'd love to hear Jim's response. So a couple of years ago, actually, we wrote, I think, the first article in the public health literature on anchor institutions, 2019. And maybe people know that traditionally universities and hospitals have served as anchor institutions, meaning they physically can't move. So they got to pay attention to what's going on outside their walls, because if their surrounding community is not doing well, then those institutions will, by definition, not do well either. So over the years, there have been so-called anchor eds, anchor universities, and anchor meds, medical institutions. And over time, they're getting more attention and more involved in building the community around them for many reasons. So to Alexander's question, absolutely yes. We'd like to see more anchor businesses too, because if businesses settle down and feel like they have to invest in their surrounding communities, we can get perhaps more investment in housing and then prevention of homelessness and other key societal advances going on. So those are some initial thoughts. But our paper was in the American Journal of Public Health in 2019. By the way, just a couple of weeks ago in New England Journal, David Ansel from Illinois wrote about anchor institutions too and cited our paper. So you may want to look at that. So thanks for the question. I don't know if Jim has more to say.
No, I couldn't agree more with you, Howard. Just a sort of a corollary thought to that, if it makes any sense. I often think that, the community we have to have in our respective communities have anchor institutions, but I often dream that HUD and HHS would be the real anchor institutions and they would work closely together, because I think part of our nightmare over time has been that you can get HUD doing a lot of stuff really creatively, HHS doing stuff creatively, but they don't tend to dovetail. And so getting those two institutions, my example is this: I remember HUD, you would remember all this, Ben and Beth Sando, who I know is HUD used to give, when they gave money, they would give a certain percentage of that to include for services in the housing that you're getting. Mm-hmm. And then over time, they decided they shouldn't be doing that. That should go to HHS. But I don't think HHS was ever able to really make creative solutions. I think they're beginning to now. But I would plead that, as we get our community anchor institution together, we also collectively work on getting HUD and HHS to work together. Thanks.
Thank you. We have a lot of questions in the chat and we do have a raised hand, but Ben, I wanted to make sure that you didn't have any more slides to present before we open it up to all the questions.
I will quickly finish my slides and then we can really have a chat and I can even see everyone's faces. It'll be great. So I think really, I just want to answer the question of what's next and what we're doing with this. And so our real goal here is to run pilot tests with small groups of our communities. We're working on scoping what that looks like now. One of the biggest things we're looking at is on the theory of change that I just shared with you. It is broad, it is ambitious, and we know that we need to narrow and focus when we're starting this work. And so we're working right now to really sharpen that with a clear focus of what we think is the most pressing, urgent, and timely issue for communities that we work with. So more to come there, but our plan is to really run these pilot tests for anywhere from 6 to 12 months, and then really try and disseminate the findings and the outcomes and any evidence base that we come up with. I think one of the key things that we've learned in running tests like this is that whether it is the project is a quote unquote success or failure, we have learned something that will either help other organizations try that in their community, or we've now kind of crossed a solution off the list that people might have tried. So we think it's imperative that we learn either way. We're ready to test things out in that space. And really, one of the biggest things we want to do with all of this is connected to policymakers, we really want to build and share open source toolkits based on our learnings as much as we can. And although we're starting this work in the Built for Zero communities, we just know that's because we have an incredible opportunity to do so. But we also know that we can't solve this problem alone. And so we want to create a space where there are smart folks like all of you who can take our work and build on it and shape it into really transformational change as we kind of really tackle this problem together. And I just want to say thank you. And I'll throw my contact information up here. We have a couple articles that just came on the Community Solutions website about some of the work we're doing. It goes into our studies in a little more detail for you as well. And my contact's on there. If anyone has questions, thoughts, anything like that, I'd be more than happy to connect with any and all of you. So thank you. And yeah, Emily, if you want to run some questions by.
Thank you so much, Ben. Round of applause for Ben and his team on this incredible work. And thank you for spending the time with us. We do have questions in the chat, and we also have Diana Barrett who has her hand raised. So why don't we kick it off with Diana?
Okay. Hi, great presentation. I learned a lot. I'm really curious, Ben, as to how you're staffing and managing this, because I would assume that you want some kind of continuity over time in each of the communities where you're doing a pilot. So there's almost like in the for-profit sector, you would say there's an account executive or someone who's really in charge and can understand the key players and the perhaps not so helpful players in each community, and perhaps the really helpful players. So how are you staffing it and managing it over time?
Yeah, I think that's one of the biggest questions that we're wrestling with right now. One of the things that we think about the most when we bring solutions or problems to communities is sustainability. And so we don't want to go in, prop something up just to have it kind of collapse after we were no longer there. So how do we go in with intentionality and enough support that this is something that they can build on their current work and they feel that is pressing in that space? I think one of the key things we're looking at right now is what kind of funding, pass-through funding, grants we're able to not only pass through to communities, but also to open them up to, whether that is partners within HHS that have a lot of great health equity programming that's coming out. But our real hope is that we can bring not only the capacity and the expertise, but also enough that they all can kind of take that, work on it together. And then like we talked about, maybe 10 years down the road, like Dr. Ko said, we could do another survey that says, this is some of the systems change that we've done. And I think that's the hope, but all this again is very much subject to the environment around us. So
Thanks, Ben.
Thank you.
Thanks, Diana. I'll start with a question that came in from Kirk. Have you seen a link between cities providing multiple services with larger macro issues like Medicaid expansion at the state level?
Kirk is thinking like us. We are starting to dig into this a little more. So one of those key things we're really interested in is, like I said, we first looked at those communities that have strong partnerships, and we wanted to just bring the question of where did that come from? What happened? What does that look like? The next kind of move is we have so many great data points in the survey now to unpack with limited staff to do it. And we're trying to really understand, like, okay, is there a trend? So we also have communities, as I mentioned, 14 of which that have achieved functional zero. One of the key things we're looking at as well is that, a coincidence? Is there situations where that is also where there are strong partnerships? What kind of complementary data we have to unpack that in greater detail. And I even saw somebody mentioned in the chat about overlaying additional data on that map that I showed earlier. And that's absolutely what we're looking at down the road. We're trying to find what is the most timely, impactful data we can layer on to figure out what that looks like in different spaces. So it's a great question.
Thank you. Brett, go ahead.
Thanks, Ben. Really brilliant presentation. And you alluded to this, but it's a tremendous amount to package and in a way that is simple enough to be sort of conversational like this. So thanks so much for the hard work that goes into that. I thought it was brilliant, the sort of the plot that you showed of sort of the number of collaborative activities between public health departments and the homeless response system. What strikes me is that the public health system, although there's great variation between communities at the local and state levels, is something a little bit more, perhaps more tangible on the spectrum of tangibility than like the homeless response system, which has even more variability. And I wonder how sort of cohesion within a sort of a community's homeless response system is largely what can facilitate some of the collaboration with the health department, and how that might be one of those kind of preconditions. And what, you know, I'm just kind of starting to turn the wheels and think about how to quantify or assess or evaluate that cohesion of a homeless response system, which is something a little less tangible today than a public health system.
Yeah, I think that's an excellent point. One of the things that I'm really curious about is within continuums of care, there are often something called a balance of state, which is largely a group of continuums of care that are kind of, or I don't know if continuum of care is the right term, but a group brought together of different counties or something like that. Here in North Carolina, there's one that spans 80 counties within the 100 North Carolina counties. And I think what something like that looks like compared to a city where there is one health department and one COC that is focused on that population, those are two extremely different things. And I think, like you're getting at, one of the inherent challenges in this is that when we talk about scalability, replicability, those are, you know, those are apples and oranges in some ways. And I think we need to be able to ask the question of what are the common grounds across that we actually can take and mirror in other communities. But one of the key things, and we're looking at change in these pilots, is we're right now really thinking, what do we want our community profile list to look like? You know, are we looking for 5 communities in Medicaid expansion states within large cities? Are we looking at 5 balanced states, or are we looking at other different kind of scopes? And so we're working with our data and evaluation teams right now to really narrow this as much as we can to understand, you know, how do we make sure that we aren't putting bias within our own experiments in that space? So trying our best. Thanks, Brett.
Thanks, Brett. We had, let me see, some great conversation going on about the prevention work that you all are doing.
Yeah, I can speak to that real quick.
That'd be great.
So yeah, Beth put a great answer in here too, but we do have a team that is really piloting a theory of change that is, you know, the same structure, but different than what we just talked about. That is all about reducing inflow. It's that what we call the housing stabilization learning cohort, working with up to 6 communities to really understand what that looks like, what these teams are. They're so interdisciplinary that they need to come together in this space. And so our hope is that by working with these different continuums of care and have them be a learning cohort, so they're going to be going through this together, learning from one another, talking about what's working, what isn't working. We are so excited to be on the sidelines and the coach of that, but we're not the ones that are doing the hard work, right? So we want to be able to have space where they can all talk to each other. And our goal is really to drive prevention strategies. So yeah, Beth grabbed some information there. Feel free to put your email in the chat if you would like more on that. But it's work that we kind of just really started over the last 6 to 12 months here, but it's extremely near and dear to our heart.
Thanks so much, Ben. I know you did touch on this at the end, but maybe if you wanted to go into a little further depth of, in your ideal mind, what would success look like for this theory of change work?
It's a loaded question. I'm gonna punt that and ask the group. So I've talked a lot. You've heard about some of the ambitious stuff we're trying to do. Let's say it is 2033 and we have been doing these type of work for 10 years. What's a measure of success that you guys would think would be worth looking at? And I know none of you signed up to think that you'd be put on the spot here, but
Maybe time in the system. You know, Amazon can get me a face lotion in 2 days, sometimes same day. So if we could be better about the point of contact and then through the system to all the things that they need and shortening that window, that might be something.
I'll throw one out there, volunteer another, which is that I would love to see dedicated whether it's a website or divisions and programming on local health department websites and teams dedicated to housing insecure and homeless individuals in that space. I think getting those positions, and I think the folks on this call and the students of the world in public health are where that work's going to come. And that's one of the things we're so excited about working with Dr. Coe and the whole team here, is that this is upstream, just like we talked about, getting all of this information and getting homelessness as a public health issue to the forefront of students' minds that will someday be leading all of these organizations and departments. And I think that 10 years down the road, if we have folks that have that as a pressing issue, that they wake up each morning within their health department and think about that as an issue, feels like a big win to me.
There's a thread in the chat that I'm distracted by because it's something I'm really interested in, which is about prevention, which is now called diversion. I'm always interested in how new terms come up out of the woodwork before we've even solved the first problem, but we seem to have a sense of if we have 3 more labels for it, it becomes anyway. I think in 2033, I'd love to look back at that proverbial bathtub image of the water cutting off at the top, and hoping that we've done some work on whatever we want to call it, but preventing people from coming into the funnel of homelessness. And we're working on a pilot here. I'm in the state of Florida, where a few good things happen, not many, but one of the things is that we are looking at a pilot looking at homelessness prevention. And it just seems crucial that we understand that and have our finger on that particular pulse in 10 years, hopefully long before that.
Yeah, that's a great response. And yeah, super important. And I also want to lift up, there's a great one in the chat from Alexandra too, about success for systems change, stable relationships, model funding for partner public health and homelessness prevention and partnerships. I think that's a great, yeah, I really appreciate that. Any other questions, Emily, from the chat or any other from the group?
See. Bob, I think, has a response to what we were talking about before, reduction in absolute number of unsheltered people in the US, and everyone working to that goal, doing so in a coordinated fashion would be success. Thanks, Bob. Let's see. I think we may have hit all of the questions from the chat. I can ask one maybe to close us out. We have some public health students on the call. For those public health, and IHH's our mission is to support those public health students who want to make homelessness a focus, and junior researchers. What are the outstanding questions that you would like to see answered when it comes to this work? Like what do you think are kind of right for student and junior researchers to dive into?
Yeah, I'll give my own answer, but I think everyone on this call would have a slightly different one, which is great. I think that was lifted up before. One of the biggest questions around this is about definitions and how different things fall into the scope of public health and what does not. I think it is, by definition, public health is a very broad term, and that is a benefit because it allows so much to fall under the umbrella. But it also can be a detriment because it is so broad that it's not specific in what does explicitly fall there. So I think, if I was sitting in the classroom and there's definitions about this work that are coming up about populations and upstream and preventative things, I think that when I would consider that, I would really think about that from a housing lens. And I think there's so many great studies out there about how housing and health are correlated and how they can really drive one another. And it's an area that I think we'll be working on for a long time. And it's a great place to consider a career path down the road. So I'll just turn that into a short elevator pitch for, thinking about this down the road. I think this is something that there are a lot of really smart, really dedicated people looking to change. And I'm just really excited to be able to talk about it with all of you.
you very much. And Sam Khan also put her contact information in the chat. She recently graduated from the public policy program and now works at Care for the Homeless. So she'd be happy to chat with any public health students interested in this work. Well, with that, I would like to thank Ben and his team for this amazing work, and thank you for spending your time with us. If there are any outstanding questions or things that you would like to talk with Ben about, he did put his email in the chat and it was up on that slide. I'm happy to circulate slides for those who are asking. And this recording will be up on our website shortly. So thank you, Ben. Round of applause for this amazing work. And we will see you all next month.
Thanks everybody for your time.
Thanks, Ben.
Thanks so much, guys. Thanks, Ben.
Thanks for